introduce myself. My name is Shay Cunningham. I am a program education director from the FFPSA Foundation. We'll talk about that a little bit later today. But my intention is to talk about the FFPSA and the rollout of FFPSA. If anybody is familiar with it, educators on what it is, I'll say to roll it out so far how it goes. So I do want to ask really quickly. It was take two. Okay. So just so I know who's in the room, is anyone in the room that has currently implemented a program for the FFPSA? Okay. Anybody else? Anybody else? Yes,
I think, being almost sure that there's you're doing a lot of work, but part of the work that we're doing is we're adding family conflict monitors and teaching on.
Okay. All right. All right. Let's stay there from that flag.
I was going to say, I was on the building purchase to studying my state looking at implementing that was resolution. I don't know where it ended up because they stayed doing the contract with building bridges out. And apparently that's when was in September, but I'm really with that. Let's see how that goes. Okay. Yes.
I think so. We are doing a pilot with one of our state agencies for family care support and combination of that. And I'm late to that particular project. I just took it over, so as I've been bringing myself up to speed, I keep running into this thing. Yeah, and so when I saw this, so I think I don't know how it all fits together.
Hopefully you will find out some information today about me. It is a beautiful thing that has its peaks, and we're going to talk about the things that are great about the FFPSA and about the FFPSA. Surprisingly, states, a lot of states have not finalized their question. What that looks like in just a second. So what its intention is for instance, right? So for many years, our federal government said, hey, we're gonna all our money to managed service, so AKA foster care, right? So there was a lot of foreign money in foster care, a lot of those kind of reactive services, residential treatment facilities. There was a lot of money that was being placed in. And so someone, right, only 100 years later, said we probably need to divert some of this money and funding to more preventative services. I was kind of like a commission around early childhood development, right? So 10 years ago, money came from every early childhood development to be preventative services development. And so now we have families and individuals, and so we probably need to divert a little bit more money to focus more on. This federal act also is intended to address. We all know that another part of our society is there's a large population of people who are and it was the same kind of process of like, hey, let's do the reactive services. Let's make sure that we have all of these, substance abuse residential treatment facilities available. But not a whole lot of prevention services for my substance abuse, right? And then foster family homesteading. So I don't know if anybody in the room has any experience in child welfare services. But Keisha was saying, and those in places, a lot of the families were not given the resources that they needed to be able to maintain these children in their home, right? And a lot of children were going to foster care because of relative condition, places could not afford to raise these children. So this is another reason, another part of it for this act. And also, its intention is to reduce unnecessary, right? So that we reduce unnecessary congregate care. And then also reunification. So there's this money here, that is out of for these money that what it wants to do is to extend reunification so that many children are reunified with their family members and or other family members and caregivers, that there is enough time to pass services in place to make sure that reunification is there. And then the population that we tend to miss always is the older youth, right? Because kids age out of foster care, there's money in this program, and also provide services to those youth as well. So each plan, so I'm going to kind of just rundown so you guys know about like why the state came about, what is it, how does it impact us in our state. So our federal government is being for $40. We found money to have preventative services, and each state has the ability to be able to create their plan for FFPSA. So the federal government said, hey, every state, I want you guys to create a plan of the services that you want to be able to provide under this money that we're going to give. So the beauty of this is that the state got to identify, hey, what is our need? Our state also got to identify what services that they wanted, for CDE that they want to put on their plan. We'll talk about that in just a little bit. Well, the main criteria for this budget was that children had to be candidate of our, right? So the interesting part of this is that every state got to create their own definition of candidate, right? So this is, I'm I'll stay away from my, my own thoughts about this, but this kind of needs to be a little bit more concrete, right? When you allow many states to be able to find them on their own, you can come up with multiple definitions of candidacy, right? But primarily what it looks like is that immigrants, right? So any child that immigrants, that definition can sometimes be a little confusing, right? So immigrants might be, hey, they're, Uncle Joe was in the house, still in the house, having sex with a minor child, or this home is so, complete and, just not clean that this child is being two very different things, right? But in the thought, and, right, so, very loose sometimes with the definition of immigrants. Or there's a child that needs to get identified on a prevention plan. So every child welfare service has, these investigations on hand. If the child is listed or identified in that investigation, and they have been put on a prevention plan, they're also candidate for foster care. And the children have to remain safely in the home while the service is being provided. So that's kind of the criteria for FFPSA funding. Again, very state specific and definition, by the state. So this was huge for our country. This was major, again, for you guys have been in social in this work for a long time. We have been begging for preventative service around families and child welfare. And so this was something that everybody got really excited about. And then, of course, what happened is, get in the way and say, and it's like, it's not, what service are we going to put on the plan? Who are we going to start with? What population do we want to focus on? So, policy, right? Again, a lot of this funding came from the state, which made it a little more complicated. So one of the criteria for, FFPSA is that when we start with the safety, they have to be an evidence-based practice that has been approved on the national standard. So those are multiple terms, right? Intercell, anybody heard of, team, our service, treatment on this, CNCBT, multitude of services.
They want to use this because they're recording.
I didn't want to use the mic. I'll use the mic for the people out there in the cyber world. So a lot of different EBPs that have, the criteria is that they have to have been approved on the clearinghouse with a either supported or will supported finding. So the National Clearinghouse is an entity that does a lot of evaluations on programs. They look at research. They have a stringent of criteria around, hey, does this evidence-based practice produce the outcomes that are sustainable? And so that's one of the criteria for FFPSA for some of our states. Now, where it gets a little, muddy in the waters is the states then have to decide which EBP they're going to use. And so that, a lot of factors are played into that. That is, where's our gap, right? Where is the population that we're really struggling with? Is it that 0 to 5, or is it families? Are we seeing a lot more families that are coming into child welfare that are, around substance abuse? Do we want to put, find evidence-based models that have more substance abuse focus? So all of those things are factors, right? And what is selected to be put on each plan. So some of the criticism, while this is a great thing, and I love it, I love that there is preventative work that is happening right now. But some of the criticism around this is that, is it really preventative, right? So, what the definition says is that, hey, you still have had to reach child welfare. You still have had to walk through their door with a concern. Is that really preventative? So that's one criticism. 12 months is the standard in which, a family can access services under FFPSA. And is that enough for those families that have been habitual offenders, right? Those families that have had 3, 4, 5, 6, 7, 8 child welfare calls, have had a long history with the department. Is that enough time? That's one area of concern. Also, a child already has to be a candidate for foster care. Again, they already have to be at imminent risk. I'm not sure how preventative it is if you're at imminent risk. And so, a lot of these things, while we love that our government has given us money to be able to provide these services in a way that really kind of takes away a lot of the red tape that we have to deal with insurances and other programs that have utilization review and things like that. There are still some areas that need to be tweaked in this, right? So as anything that is new, when it's rolled out, what we are looking for right now is a lot of data, right? To support, well, how is this effective? And we're going to talk about so far how it has been effective. So just a little interactive activity, like if you had no rules, okay? No rules at all. What ideas would you want or would you have to be able to serve families effectively? There were no diagnoses, right? There was no time frame. There was no, all of the red tape that we have sometimes. What would be some ideas that you guys think that you would have if you had it your way? You could create your own way to serve families. Anybody want to just take a guess or shout out, something that you thought about and was like, that'll never happen?
We take parents as teachers, but just something to say.
Yes, absolutely. Right. Absolutely. So what I'm hearing you say is that it really, if someone needs services and they,
are willingly capable, able to come and get services, they should. It shouldn't necessarily be an approval process, is what I'm hearing you say. Or eligibility. Absolutely. Perfect. I love that. Anybody else? If you had it your way. Mhm.
They should decide, like, someone should be looking at this film, and I know it's,
Yeah.
having a conversation. They don't want to see how they each other. If they were to do that, I kind of feel like we need to get should, they forget about it.
Yeah.
Like, it's just like, I don't know, like, there's nobody honors right there.
Yeah.
You know what I mean?
Yeah.
So, what about the information trickling down the state?
Absolutely. Yeah. Yeah.
So some type of oversight
Yeah. Absolutely. I love that. And to be quite honest, I've worked in child welfare, and you're right. Once that we're like, you're gonna take them, okay, and then we're out forever. Yeah. Right. Completely understand. Yes, ma'am. Yeah, absolutely. Yeah. Mm-hmm. Absolutely. Yeah. I met a lady in Europe several years ago, and she told me about her experience as a social worker. And at the time, I was working in child welfare, and I was like, people hate us. Like, people hate us. And she was like, people love us. And I'm like, what are you guys doing over there? And from the birth up until I think 8, maybe 10 years old, everybody gets assigned a social worker if they want them. Right. And they get the services and they get the education and they get all of these things that people don't even want their social workers to leave. Right. So different perspective and like intention, right, in other countries and how social workers are being used. And this is, if you're having a kid, I want to make sure that by the time that this kid reaches adolescence, that he or she is developmentally appropriate, has gotten the services that they need, have gotten all of their medical concerns, all of those things, right? And I have held on to that conversation for over 10 years. And I'm like, man, how awesome is that, right? To have some support built in at the time of birth. You were going to say something.
One step beyond that, but I love that. Those really moving programs. Look at who your referral sources are and embed kind of connections between the organizations that support in those referral systems.
Yeah.
So if your referrals are coming from Seattle,
Mm-hmm.
then who is doing kind of early outreach in these guys before they're in trouble?
Yeah.
I ran a family organization. We had funding for training, so I could do anything I wanted as long as I did the training that I was paid for. And we went in with families to and kind of avert their CPS kind of involvement because we were in WIP and they didn't see us. They saw us as support.
Yes.
They saw us as support. And we were hoping to keep them of that system. And conversely, it's what my members do, students are teach. I've done that with students, putting them in supported counseling with folks that, were in trouble and getting ready to lose their kids. But in fact, one of them was a lady who was illiterate. They were giving her written information and you think she was not compliant because she couldn't read.
Yeah.
She was just being nuts. She just couldn't.
Mhm.
Yes to what her say, but she can't read.
Yeah. Yeah.
Because she was not on my.
Mhm.
She was. Today.
Oh, yeah.
So the students, getting students in there, evaluate kind of what was really happening.
Mhm.
And, but we didn't continue the CPS, which came into the support.
Yeah, so I'm hearing that CPS shouldn't be the only door, right? For families to be able to get services. And unfortunately, with this act, CPS is the only way to be able to access these fundings. One of the things that usually comes up when I do this presentation, or, you know, when I've heard about some ideas from community partners, is that the case also should not remain open, or the preventative services should not be contingent upon when CPS closes their case. And unfortunately, right now, that is how it is set up, right? So if I come in and I want services and my door has been through CPS, if they say, hey, you know what, we're closing our case, you're not as important as the other 15 cases that I have, I got to start closing some, then that automatically cuts your services off with this act, with these funds. So it's unfortunate, right? Especially for evidence-based practices that families are going through very specific services or models that, you know, part of the funding stops if that case is closed. And so sometimes we're going to see progress and we're going to see regression. That is the cycle of change, is that you're going to see some regression. And sometimes we don't, you know, child welfare services, local child welfare services don't allow that entire process to happen. So does it really help if a family is not able to get the entire length of services, right? And so that's one of the things that we've also come up with as a criticism is that, hey, if a family is receiving services through FFPSA, they should be able to receive the entire service, right? And so if that case is being closed, should a family suffer? You know, there was 99% issues with retention in Arkansas with local DCFS. I mean, every week there was turnover, right? And so imagine what was happening to some of these families who were receiving services under these funds, because if you come in and as a social worker, you're overwhelmed, well, I'm going to start looking at my list too and see who needs to be closed, right? And so it was really disrupting family services. And that was super unfortunate for families, because ultimately what we saw is that those families who did not get through services successfully were coming back into the system. It defeated the whole purpose, right? Especially the purpose of prevention. So again, those are some of the things of this that definitely need some tweaking. It needs some, you know, lobbying. It needs a lot of things to be able to shift. The overall intention of this act was good, right? But we still have some work to do. So I want to talk about very specifically FFPSA in Arkansas. So you guys may have seen on your agenda that I was supposed to be co-presenting with a colleague of mine, but she had an emergency this week, so I had to come in and do the whole presentation. So you guys bear with me, because part of this was not mine. So FFPSA in Arkansas, she was the program director, vice president of prevention services. And so she started up a program in Arkansas, intensive in-home services, in 2019. And they use family-centered treatment as their evidence-based practice that was approved by their state plan. And it was phenomenal. And it is and has been phenomenal. So Arkansas was pretty aggressive with their prevention plan that they submitted. They started transitional funding. They got families in services. And I want to talk about some of the data that has come from their implementation with FFPSA. So FCT, family-centered treatment, is the evidence-based practice of choice. It was on the Arkansas state plan, and this particular organization decided to use FCT. So 99% of families had not had a confirmed finding of abuse or neglect. from July 2019 to July 2020. And the state requirements or expectations was that it was 90%. 99% of families maintained in the home during treatment, which means that while that treatment case was open, none of those children were removed. And the state's expectation was 95%. They provided provided services to 196 families in 2021. And there was a 44% reduction in foster care entries within the first year of implementation. That was huge. And it has been so huge that Arkansas has decided to implement family-centered treatment statewide. That is a significant reduction in foster care entries. And it took a lot of work, right? As everybody was new to family FFPSA. And that means that we had to educate judges and we had to educate DCFS or local child welfare offices to say, give us the opportunity to work with these families in the allotted time, right? So I talked about earlier that cases were being closed prematurely. Families weren't completing services. A lot of education went into that, right? So a lot of partnership had to occur. And this is something that, with this federal money coming down, nobody teaches you how to do that. How do we play nice, right, with each other? We both have a common goal. And how can we work together to create that common goal? And so with anything, and any of you guys who are getting ready to start this in your states or are going to be a part of this, there's a lot of uncertainty at implementation. And that is that, hey, who are these in-home people? So, who got nervous? Local mental health agencies, because they said, oh, you guys are going to come take our jobs, right? Who else got nervous was child welfare workers, because, somewhere along the way, they said, well, if you guys are in the home, what are they going to need us for, right? So everybody was really nervous about what the intention was behind this, and a lot of education had to occur because everybody wasn't playing nice, and it was out of fear, right? And so, that's one thing that, we had initial struggles with and really, really had to sit down and say, hey, we're not here to take your job, right? We're here to change your job so you don't have a caseload of 50 or 60 families, that you actually have a manageable caseload because you don't see the same families coming and cycling back in through the system. So really, really good outcomes in Arkansas. The stakeholders. So we sent out surveys, and we do this every year since we've implemented in Arkansas. And some of the stakeholders, these are state representatives from DHS. These are state representatives from juvenile justice. And one of the things that I really, really appreciate about the stakeholder feedback is that they said this has shaped and changed the way that we do business, right? And so one of the things that's super important about community-based services, especially when you're working with systems of care and different entities, and there's, 4 or 5 people connected to one family, is what is our common goal, right? What is our common goal? And after speaking to one of the state representatives in Arkansas at DHHS, she said to me, Shay, this program has really shifted the way that we do work in our own culture. This program has taught us how to approach families differently, right? And so that's powerful. If we had never had the outcomes that we received in the first few years, the fact that the culture of child welfare system in one state said, hey, you helped us change, that is significant, right? Very proud of the work that we did. Even in juvenile justice, one of the juvenile justice state representatives, her feedback was that the youth is sentenced to us and treated in a controlled environment. We don't always see the true results. With this process, the youth are receiving treatment with a family unit in their own environment and get to advocate for what they need. Just in juvenile justice, specifically in Arkansas, there were fewer kids that were reoffending after this service. And so, the results are phenomenal. They are phenomenal. And it has been such a big thing in Arkansas that not only has, through FFPSA, Juvenile justice wants to get on the bandwagon now. Medicaid wants to get on the bandwagon because there have been results. And what we do know is that if we truly do preventative services, right, it saves a lot of money to states. It saves a lot of money. And to be honest and fair, and we're gonna talk transparently, the people at the top who are making decisions sometimes are just looking at a dollar, right? And so because we're looking at a dollar, then sometimes we have to use that language. And honestly, these services have produced enough results to say we're saving money, because nobody's going to implement something statewide if it's not saving them money, right? And yet alone the great outcomes that have come, because that's my focus, right? That's our focus. And people in this room, we're more concerned about quality of care and families getting better. But if you do it correctly, what people are finding out, especially state officials and people who have the purses, is that if you do it correctly and you allow us to do it correctly, in the long run, you save money, right? That's the intention. So what the practitioners are saying, so the people who are doing this work, so specifically in Arkansas, what we have learned is that these numbers and outcomes were done with bachelor's level staff. And some people say, hey, we want master's level clinicians, we want them to be licensed, and this work was done with bachelor's level staff, QPs, qualified professionals. And so what they say is that, hey, we love this organization. They had the lowest number while it was a revolving door at DCFS and our child welfare services. These people who were serving those families had the lowest amount of turnover. And some of them, most of them are the people who started in 2019 are still there. And that speaks volumes around retention. I heard earlier this morning that workforce is an issue, right? Everybody know we are in the Great Resignation, right? So this is a huge issue that people are actually feeling like, and I don't know how many clinicians are in the room, but as a clinician myself, you know, it really beats you up and beats you down when you feel like you have gotten a family that is so unsalvageable, right? They're so far gone that there's nothing you can do with this family anymore. So think about how many people feel more successful, not just families, but practitioners. And if they feel successful, because we know that people don't get into this work for the money, right? That they want to feel that success and that they're helping people, how many of them will stay? Right? That is exactly why they get into this work, is to feel like they are providing help, support, and hope to our families. And if our practitioners don't get that opportunity to do that, then they're out of here. And this is why, you know, there's such a huge retention issue, is because we've always been reactive in the services that we provide to families. And this is another way for prevention, for people to be able to hold on to good staff. So what are the families saying? So this is just a small sample of some of the things that families have said, is that that we were treated like people. Our clinicians seem to care about us. We loved our clinician. I know how to handle day-to-day issues with my son, and I've learned the importance of follow through and why I need to be accountable for him. I know how to manage my kids' attitudes better. We all probably need a little bit of this service there. You know, just very accepting. So very positive feedback from the families. And for someone who does research and analyzes research and collects research from organizations, you know, as I was always pulling a report together and finding this information, this was the first time in a couple years where I got a little emotional reading, you know, these responses from families who are receiving this service that say, hey, thank you for stepping in before it got too bad, right? Thank you for acknowledging and getting in here before it got so bad that my children were removed from the home, right? This is our family's way of also saying, like, we need this preventative work. Like, we need someone to intervene before it gets this bad, right? So I want to talk about really quickly, going the wrong way. Can you go back to the slide? Yes, I think I got it from here. But I want to share just one story, and the reason why this particular family is so significant, and I want to talk about them before I open it up for questions, is that this family in Arkansas decided that they were going to the news themselves. And you know, sometimes when we hear that, it's always bad, right? It's always a threat. Like, I'm going to the news and I'm going, you know, do X, Y, Z. So for a family to say we're going to the news, of course, we're all like, what? What you mean? And this family really wanted to share their journey in this service that they received. So I'm going to give you guys just a little bit of time to read through their story, and they gave us permission to share their picture at the end. But I'm gonna give you guys just a little bit of time to look at their story that they wrote up for their local newspaper, and they said, we're gonna let everybody in Arkansas know about this service. Can I move forward? Okay. Can I move? Can I move? And this is them. This is Tammy and Aviana, and on the right-hand side is Miss Whitney, who was their practitioner. And it was such a beautiful, beautiful story. Every time I talk about it, I get a little emotional. Just because we see so much success, you know, with our families, but when someone wants to spread this information, right, and they want to, you know, to share with their community that, you know, try it, you know, we learned a lot. So I do want to open it up for any questions that you guys may have. Yes. I'm sorry. FFPSA, family, oh my goodness. Yes, Families First Prevention Services Act. 2018, I want to say. So there is a website that is on the last slide. We have uploaded this into the application. And there's a link there that has Family Preservation Services Act, and you can go to your state and see what is on your plan. It outlines everything, whether your state is in transition. Some states have not finalized their plan. I believe, don't quote me on this, that states have until 2024, I think, to finalize their plans, 2023 or 2024 to finalize their plans. And some states are still in the process of trying to figure out a lot of things, you know. Some states have been a lot more aggressive with this, and results have already been, you know, present for them. I have my own thoughts about why some states are lagging in this. I always like to say it's free money. Like, why do you don't want free money, right? So it's interesting to say the least, but I'll stay in my scope of practice. Any other thoughts or questions about, yes?
So family center treatment is that.
It is. It is. So family-centered treatment is a evidence-based practice that is approved by the clearinghouse, and it is one of many evidence-based practices that are being used right now on state plans. So Arkansas chose to use that for their intensive in-home services. So their community-based services. It is a pretty intensive program that is done in the home. It is a trauma treatment program that includes the entire family. So it has given phenomenal results in Arkansas. They do, yeah, they do. You do need certification. So I'll talk about that specifically with family-centered treatment. So there are other EBPs that may be on a state plan that have completely different criteria. But for family-centered treatment specifically, staff have to go through a one-year program for certification. So they do go through certification. There is extensive training. There is extensive online training, and they also have to demonstrate competency in the field. So there is, we screen them pretty good, you know. So yeah, and you know, one of the great things about that specifically, and I want to kind of stay, I don't want to, you know, solicit, but one of the things specifically around that is that what we have found is that with the right amount of training and the right people, really the degree doesn't matter, to be honest, you know. And what we have found is that there has been probably, if not more, better results from people who stay at organizations. And what we found is that people, I won't say all, but what we have found in our research is that there's a higher retention with bachelor's level staff, and they can do just as, if not better, work than licensed folks. And it all really comes down to training. And that is a large component specifically of family-centered treatment. A lot of training. Good question. Anybody else have any questions? So referrals come directly from the local child welfare system. So their local DCFS offices, usually referrals can either come in at investigation. So there is a, you know, case has been called, hotline call has been made. If there is some concern, but maybe not enough to remove, then those cases are identified for FFPSA or intensive in-home services. So it's a great question. So exactly, absolutely. And we all know that typically when we have children in the home that may be experiencing some issues, that everybody wants to blame who? The kid, right? And so one of the ways that goals are being worked on is, of course, there's a goal from DCFS Child Welfare Service, because they want to be able to create, you know, a measurable way for them to be able to exit. But the family also creates that. So there's a wide variety of assessments that are being done in family-centered treatment. And at the end of those assessments, the family creates their own goals. What do you guys want to, based off of what you learned in the last 30 days about your family, what now do you need to work on? Right. So the family also they create their goals, and also there are goals that are identified from child welfare services for them to be able to step out. I'm sorry. So yes, there has been times where there has been a removal that we have still been able to work with the family, or there has already been a removal and the child is re-entering into the home. So there are multiple ways in which a child or a family can receive services. We have had families that parents have had significant substance abuse. And so they may have needed to go to a 30-day inpatient. We continue to work with that family as that parent is coming back into the home, right? We've had children that have been in foster care. They are coming back into the home, right? Reunifying with that family. So we've been able to start services with those youth as well. In the foster home or in residential treatment facility or even in, juvenile detention centers. So yeah, reunification, a large percent though. I will say this is that the state also has a lot of control over how much money is spent on reunification versus stabilization. So a lot of states, well, what I'm seeing, I won't say a lot of states because every state has not finalized their plan, but a lot of times the states want to really kind of stabilize the children. So a lot of the funding is around keeping them before they even get removed versus reunification. So yeah, I mean, it can be multiple things that they decide that they want to do in terms of, the services. It's so interesting that you asked that question, because in the initial implementation of intensive in-home in Arkansas, remember I told you everybody was like, had their eye open and was like, what y'all doing down here? And so once everybody stopped being scared that their job was at jeopardy, we invited those workers into some of the sessions. And that is what created the partnership, because some of those families were not letting those DCFS workers in their home. Right. And so some of those DCFS workers also wanted to know, what are you doing? So there are several assessments that we've invited them into the home and said, hey, look, sit down and listen to everything that's going on versus what you see on the surface of with this family. And they have been amazed. So much so that we have had to kick them out and say, no, you can't, you're not a part of the family anymore. Like you can't come back we just want to give you a sneak peek of what's happening here. But I mean, it has been pretty amazing for them to be able to see some of the process. And to be quite honest, if you worked in child welfare and you're making a referral to a provider agency, you don't really know what that looks like for a family. And so one of the things that specifically that Arkansas did was they invited them into the house, right? They got the family's trust to be able to say, hey, these people need to know more about you than you made a mistake, 2 months ago with your kid. Right. So it was phenomenal. It was a great way for that partnership to happen and for providers to see what, for DCFS social workers to be able to see what really this service is about. So that was that was an integral piece. And everybody plays nice now, y'all. Like everybody's at the table playing nice and we high-fiving, like we good. Any other questions? Yes, so there is a system that they have. The provider can't access it, but they do receive information out of the state database. We, as the FCT Foundation, we also produce data that we share with both the providers and the state. One interesting thing too about FFPSA is that usually states will do an external monitoring and evaluation of the services as well. So they have an independent evaluator to say, hey, how are these services really going? Are we seeing recidivism with these families? And since 2019, there has been positive results, even from the independent evaluator that says, this is solid. Like this is pretty good. Yes. It is. So family centered treatment is the foundation, is the entity that owns the model, right? So as the entity that owns the model, we license organizations to use the model. So right now we have approximately 37 organizations that are licensed to use family centered treatment, with our most recent being in Texas and Virginia. So organizations actually reach out to us to say, hey, we want to use this evidence-based practice, and we go out and help that organization implement it, start it up, train them, all the things that it needs to happen to be able to implement that successfully. Good questions. Any other questions, ladies? Yeah, you can ask as many as you want. We do satisfaction surveys, and we do that from the foundation. So our families get family satisfaction surveys that the organizations that we license don't get. Like they can't tweak that, they can't manipulate that, that comes directly to us. And we disseminate that out to the state, to the provider, whoever really needs it. But every family, we do have a system that every family that has completed services, or even if they just closed and they didn't get through all of it, has the option to be able to complete a satisfaction survey. And it's pretty thorough. You know, it's like, hey, tell us what you didn't like. Tell us what you like. How often did you see your practitioner? You know, what did you learn? You know, how much was telehealth? There was a lot of questions in there for families to be able to give us some really, really good data around what's really happening in services, and it has been really positive. Good question though, and you can ask another question. Yeah. Well, so the FCT Foundation requirements is that there's at least 2 multi-session hours per week. So at least 2 times minimally at 2 hours per session. So that's about 4 hours, but a state has the authority to say, hey, we want those practitioners in there a little bit more. So in Arkansas, they have just said that every family needs 6 hours. So they're at the home 3 times per week, 2 hours per session. And this is a combination of multiple things where it's not, you know, every session is not just a family session, but there's individual work sometimes that needs to be done with parents. There's generational trauma that is happening, that is being addressed also in these services. So it's pretty intense, you know, and if that's that's usually the one thing that families complain about is like, we see y'all all the time, you know, and we like to say, we just become a extended part of your family, you know. But it is a pretty intensive service, and typically it is 6 months, but it can be shorter depending on the needs of the family. But the average length of treatment is 6 months. It does, yeah. Exactly. Yeah, absolutely. We make those accommodations when needed. And sometimes our families are, you know, living with another family, you know, and we have to be considerate of that as well. So there are absolutely times where we bring them out into the community or bring them back into the office if need be. But we want to be able to see those dynamics, right? Because the difference between an outpatient setting and a home setting is that you comfortable, right? So even if we don't see 100% of you, we're gonna get about 75%, right? And we do, yeah, absolutely. And to be quite honest, you know, at some point over 6 months, you know, even if our families, and I say this all the time, is that you get exhausted acting, right? So at some point we're going to see the real deal. And that's what we want to see, is our families in their most vulnerable state, right? Because that's the part that needs healing and help, not the representative of you, right? No, ma'am. No, ma'am. And it's not traditional. It's not traditional hours. That means that if you're having issues at morning time, getting your kid on the bus, we're there in the morning, right? If you're having at bedtime issues where you can't get kids in the bed, we're there at night. So it's a lot of flexibility in this model that creates that level of success where somebody's like, hey, I'm gonna see you every Tuesday and Thursday at 2. That might be your peak. Everybody might be happy at 2 o'clock, right? So, you know, that level of flexibility is also needed to be able to see, you know, a family at its best and its worst. Good questions though, ladies. Anybody else have any questions? I think I have kept y'all long enough. It's 5:31 on the dot. Thank you guys so much. I appreciate you guys coming. And all the information is in the app. So contact information, links, websites, all those things. Okay. Have a good day, ladies.
Yeah.
There's actually very little video website that gives you the site of the institute. It's called yes. I saw she didn't present. That's okay, yeah.
It's, we got into keywords and things, trying to clear this, one of the license that goes for things that you might.
It's fascinating, FFPSA was dropped. Great such a year.
Oh, yeah. She was not really good with that. Like, he was not communicating well, he was not into.
Like, how can you make the worst moves tactically?
Yeah. Absolutely.
Created a real mess, and so people are still trying to think about, like, but whether it's the PC, doesn't really tactical move, because they're like, sphere, like, job, not really relevant.
And they were about that. Completely not what I'm making.
They had to overcome those stairs because it was a harsh.
Yeah.
It was not small.
Right.
Yeah. So anyways, I really want to collaborate with folks like yourself that are doing it. My model is supported model on say, but for me it's been not taking two roads, but one is the full system of care, which is the space model, that's the right also when you guys I can still only really tools. At the end of the day, my bio animals better workforce. So either way, I get my life to help train our workforce trauma response. Yeah. So you were coming in and I was teaching.
Yeah, probably, yeah.
Yeah, that's just a vital question. Motivational question that you do on the phone. For example, we used to be in the center, they adopt that phone call that every Saturday will show. Wow. That's that's the new one. When I was talking, that was something I was fighting.
Yeah. My, people, here, and I'm
You're having a part of the future.
very nice to meet
It's like, that's how.
you have a good one, I understand.